So, right. 45-year-old male, diabetic, hypertensive, anxious regarding history of family history of ischemic heart disease, and that's his ECG. What we're going to be focusing for the rest of the session is on electrocardiographic diagnosis than clinical diagnosis. Okay, shout out.
A normal ECG.
Normal ECG, okay. Any more?
Yeah, sinus rhythm.
Keep going. Any other? But there's something in the chat box. Normal sinus rhythm. That's not the right way to summarize the ECG. I'm really sorry. You should just say sinus rhythm, normal electrocardiogram with no obvious abnormality, because the moment you say normal sinus rhythm, it just means it's sinus rhythm and not something else. Okay? So phrasing is important in summarizing an ECG. So this is a normal 12-lead electrocardiogram. Okay? Would you reassure him, or would you send him for some tests?
Just reassure him.
Reassure him. Excellent. Lipid profile. Yeah, I mean, he might have all that perhaps through his GP. Okay, next one. 52, irregular pulse, hypertension.
Sinus arrhythmia.
Well done.
Sinus brady.
Yes, that's also correct. But what's apparent? I mean, in the context of irregularity, he had a 12-lead ECG.
It's irregular.
Sorry, go on.
An irregular rhythm, and there are different numbers of squares between the complexes.
Yeah, but what's apparent that there is an established
P waves prior to the QRS complexes.
Yeah, atrial and ventricular relationship across the electrical cycles of the heart with a bit of irregularity, and that's what is a classic sinus arrhythmia. It's a physiological finding. Again, you would just reassure the patient. Some people can be symptomatic, but they just need reassurance. Right. Who wants to go for this?
ST depression in the anterolateral leads. And in the inferior leads as well.
Okay, so how does anybody else want to summarize this ECG?
Are they having a STEMI?
Can someone see ST elevation?
In the AVR leads, there's ST elevation.
Okay. So what do you call this as STEMI?
You mean by recent onset angina as in they have chest pain?
Yeah.
So then it could be a posterior.
What are the criteria for ST elevation myocardial infarction? ECG criteria. Anyone?
Is it 2 millimeters in the kind of V1 to V6
change or 1 millimeter in the central ones, and it has to be in not consecutive leads but concurrent leads.
Yes, Lydia mentioning 2 millimeter elevation to contiguous 2 millimeters or more and 1 millimeter or more in the limb leads. You could then say ST elevation myocardial infarction. There are lots of possibilities here, but you need to stick to electrocardiographic diagnosis. And that is, you've got anterior, most of the anterior leads have horizontal / downsloping ST depression. The inferior leads, mainly lead 2, and a little bit in AVF, lead 1, ST depression, and elevation in AVR. So what do you want to primarily, are you worried about this patient? Why is he breathless?
Pulmonary edema.
Yeah, it could be in congestion, and of course, this is just ECG what we're talking about, but he could be in acute pulmonary congestion as a result of, something which is going on and raising his filling pressures. So that doesn't look good in terms of how it looks. So you're going to treat him as?
And STEMI?
We haven't done a troponin, so you can't say myocardial infarction.
Acute coronary syndrome.
Absolutely. So treat him as NSTE or non-ST elevation ACS. Okay? So phrasing is important. NSTE ACS rather than STE ACS or STEMI, right? And then
Why could this not be a posterior STEMI? Like, would you not put the posterior leads on to check?
it can be. You can't say that it's not a posterior STEMI, but in all probability, with his presentation, in the absence of any obvious chest discomfort of the type of discomfort you might expect in a classic scenario, you would potentially treat it as an STACS. Now, the decision to move on to the invasive management is a different matter of discussion. You know what I mean? So the differentials, as I said, are pretty much slightly wide here. Posterior STEMI, but for practical purposes, what you're seeing here is what could be an infralateral end STEMI, or rather widespread ischemia, left mainstem disease, so on and so forth. So in all likelihood, this patient is heading for the cath lab, but you would like to do that once you've assessed them, they're clinically stable, so on and so forth. Are you happy with that? Okay. I didn't get an answer. Shall we
Yep.
move on?
Yep.
Joseph, please chip in if you can, okay?
Yep.
Okay, guys, take a look at this. Elderly man, tiredness, pretty high blood pressure. We're just talking about electrocardiographic diagnosis, ECG diagnosis.
This is complete heart block.
Complete heart block. Could somebody explain the findings? Anybody?
The relation
in the atria and the ventricles. They contract at different times.
I'm sorry. Say it again.
There's no relation between the P waves and the QRS, so it suggests that the atria isn't communicating with the ventricles.
Atria is not communicating in ventricles. Okay. Any other way of describing this?
There's a dissociation between the P waves and QRS complexes.
Okay, that's slightly better, I would say, certainly. So there's a AV or atrioventricular dissociation with P waves marching through the QRS complexes and often deforming them here and there. So you could say it in different ways: complete heart block, complete AV dissociation, so on and so forth. And what about the underlying rhythm? What's the heart rate? And why is the blood pressure so high? Have you seen patients with complete heart block and high blood pressure? I'm sure you would have. Yeah, so
Normally they're hypertensive.
yeah, so why is the blood pressure generally high in a lot of people who have complete heart block or 2 to 1 AV block or heart blocks or bradycardia, to be honest?
Are they
Just
trying to
wondering-
compensate and they've maybe been in it for quite a while?
Well, basically the bradycardia means they have enough time, a reasonably long time for diastolic filling. So the stroke volume is pretty high. Okay. And if they are hypertensive as a baseline, then you can expect them to be in hypertension. But then this is a very dodgy situation because they could go down anytime because this can degenerate further. They're having a decent escape rhythm, but they could suddenly go PPPPP with no QRS, and that's effectively a systolic rhythm. Okay? So they need to be admitted, they need to be observed with the backup temporary pacing if necessary, and being listed for the first available after assessments for first available slot for permanent pacemaker, which is usually the next day or the same day perhaps. Okay, next one. Go on.
Anterolateral ST elevation ACS.
Anterolateral ST elevation ACS or anterolateral STEMI. Either way. What about the inferior leads?
Little bit of elevation.
So which leads have ST elevation? How much ST elevation can someone see in lead 2 and AVF?
In 2, maybe 2 millimeters in AVF 1.
Yeah. So does that qualify as STEMI?
Maybe.
Yeah. Ellie, it's quite elegantly summarized. What about lead 1? A little bit, I guess. So, I mean, I think this was a patient I remember had pretty a very hyperdominant left anterior descending artery, which was wrapping around the apex with a small right coronary, and had an occluded proximal, late proximal LAD, and that was perhaps explaining this wide range of segments corresponding to the ST elevations. So it's just a slightly different just to kind of provoke you into thinking that sometimes you can see things which may not just correspond straight to one territory, but could be cross-territory, could still be STEMI, because traditionally cross-territory means it's something else. Okay. Right. Desaturation, breathlessness, IVDU, 47-year-old. How many people we have so far on chat? Okay, we've got 70. Excellent. Do you want to keep going for some time?
Yeah.
Yep.
What time do you want to finish? Just type in the chat box and then we can. Oh, there's loads. Don't worry about them. You decide the time and we can finish. The hundreds. Okay, we'll see it. Okay. Yeah, we scheduled it for 4:30. We are 2 minutes from 4:30. Sometimes people like to discuss ECGs, so but just look at this one and tell me what you think it is, perhaps. Don't worry, those who have to leave will have a recording available to view. So this is a right bundle branch block pattern seen on the ECG. Put that into clinical context, and you see desaturation, you see breathlessness in a IV drug user. What comes to your mind? What clinical condition? Pulmonary embolism. Quite correct. So right heart overload, right heart strain, whatever you want to say. So that's a classic one from that point of view. And you know, I wouldn't want to go into the management, but this was just to review. This was a real life case from acute assessment unit, and the patient was offered quite advanced treatment with quite significant improvement in his condition pretty rapidly. Right.
Can I ask what the cause of the T wave? He's got T wave inversion of V1 to 3.
V1 to V3, that's a secondary T wave inversion. So that is just to be expected. So there are 3 conditions where you expect the T wave to go down, to go in the other direction of the dominant QRS wave. So here, if you have the dominant QRS deflection in the up direction with a broad QRS, 3 conditions, remember, bundle branch block, ectopic beat, and paced beat, all right? All 3 will follow the same rule of secondary T wave change, which is the other direction. So that's secondary T wave inversion, not an ischemic change, mind you. Does that clear?
Yeah, thanks.
Yeah. So that follows the same rule for all 3 conditions. So LBBB or RBBB, paced beat, and ectopic beat, ventricular ectopic beat. Okay. So yeah, PE. This one.
CT.
Yeah, so that's a classic case of narrow complex tachycardia. What rate do you think it's going on at?
Around 150 beats per minute.
Yeah, so I can see about two big squares, so that makes it 150. And what would you give? dizziness, palpitations. You've tried all those maneuvers.
Adenosine.
Adenosine, yeah.
What doses?
6, 12, 18.
It hasn't worked.
24. You could try. Or another 18.
And want a friend from cardiology, or would you give something else and try and see?
Beta blocker. And then again with adenosine.
Yeah, so I think there's loads of options, to be honest. I mean, that's what I wanted you to keep in mind, that always have an open mind. If adenosine doesn't work, think of problems like accessory pathways in the background. Think of circuits which are not responding to what adenosine is meant to do, is to break the dual AV nodal physiology. And that may not be the reason for SVT in this patient. It could be AV re-entrant tachycardia, either with or without an accessory pathway. So you may have to use additional medications to block the AV node in different ways, so on and so forth. And in the end, if you're running out of options, what would you do?
Cardioversion.
Yeah, I mean, depends how the blood pressure is, how difficult the situation is. It's generally not required, I would say. I mean, it's long before I had to cardiovert somebody in SVT, even though I think I remember one patient being cardioverted because of hypotension. And that perhaps because there was loads of medication given already, and then still the SVT was going on and on and on. And when cardioverted, patient went into AF, so on and so forth. So yeah, so just keep in mind, treat it like SVT unless and until proven otherwise. Okay, elderly collapse is on beta blocker and apixaban. That's one ECG which you might not see very often, but if you see once, it'll stay with you.
Is it atrial flutter?
Atrial flutter, indeed, or AF, whatever you might want to say. With what?
Is it like a 5-to-1 block or something?
So when you say 5-to-1 block, I mean, can you see that there are differences in the? There's.
Yeah.
What about the heart rate? Is that regular, irregular?
Flutter with variable conduction.
So it's irregular, you mean? Variable means irregular. So when you see such an ECG with a regular heart rate, mainly in AF, if not flutter, think of complete heart block. Okay, especially elderly patients, over-medicated. And this could be a 6-to-1 AV block, but then you need to see a certain amount of atrioventricular relationship here, but you can't see that. You can see that it's marching through. So it's more than likely to be flutter with a complete heart block with a narrow complex escape. You will see some of it going forwards now and then. But remember, regular heart rate in AF means complete heart block. Okay? Pregnant lady, intermittent palpitations. Who's got the diagnosis? Electrocardiographic.
Right bundle branch block.
Right bundle branch block. Okay, well, you might get some points for that.
Some delta waves present in the
Delta wave. What is a delta wave?
It marks an accessory pathway. Or
So what is a delta wave? I mean, this is what I want you guys to get down to, the very basics, isn't it? So sequential analysis of ECG, if you just map this one out, you got this P wave or electrical or atrial activity, which is shortly followed by a slurred upstroke of the QRS, then a rapid downstroke, and that slurred upstroke preceded by a short PR interval is what's called a delta wave by definition. Is that okay? So two components to it: slurred upstroke preceded by a delta wave and broadening of the QRS complex as a result. Can you see this is broader than what you would expect because it's slurred? So yeah, it's correctly delta wave, short PR interval. So it is a classic Wolff-Parkinson-White electrocardiogram in a pregnant lady with intermittent palpitations. You'll try and get her through the pregnancy somehow and then sort her out either through medical management, conservative treatment, or via getting her electrophysiology guided ablation, whatever is more appropriate for her at the time. Is that clear, this one?
Yeah, it's also very conspicuous in V5, V6.
Yeah, it is apparent in most leads from V2 to V6 onwards, and also in the inferior leads, in the inferior leads in a negative direction, as you can see. Also in lead 1. So it is, it can't be missed, I guess.
right.
Okay.
Notice why why the R is so large in V2 to V4.
What do you mean? Sorry, I didn't get that.
So why the R waves so?
Well, that could be due to body habitus. That could be due to it's generally due to constitutional reasons than anything else, unless there is a big deal of hypertrophy, in which case you expect both positive and a negative wave. So all it means that there's early transition. You can see that, or maybe how the leads are placed. So there's loads of reasons why you see voltage change across the chest leads. There is a big differential. The most common reasons is normal variant, constitutional reasons, body surface, so on and so forth, lead placement, so on and so forth. So okay.
Thanks.
And if ever in doubt, I think most of the patients will end up getting an echocardiogram, but this would need an echocardiogram anyway for her structure and function assessment. You don't expect her to have ventricular hypertrophy. This would just be classified as a normal variant in terms of the height of the QRS complex, as rightly pointed out. Well done. Okay. Young male, syncope, 2 episodes. What do you think might be the differentials? Or based on ECG first? Describe the ECG. Maybe we'll finish in 5 minutes, if that's all right with you.
T-wave inversion in all leads.
Okay, so what is the most striking abnormality? So that's how you see ECGs, as either there'll be something, nothing, or there'll be something very striking. Okay, if you just, after the session, when you reflect on ECG, just think about there'll be something, there'll be nothing to note, or there'll be something strikingly obvious. So what is strikingly obvious on this electrocardiogram? In the interest of time, perhaps I would say that the strikingly obvious thing is the giant, deep T wave inversions along with ST depressions across the anterior leads, majority of them, except for leads V1. Is that correct?
Yeah.
And also minor inversions or milder versions in inferior leads. So just a quick one. Yeah, who said how come? Yeah, that's fantastic. So you would suspect, you then start to worry about the context. So if this was a 65-year-old with chest discomfort, you start to think about whether it's a Wellens syndrome or what we call as a proximal LAD severe stenosis and acute coronary syndrome of NST elevation type. When it's a young patient with syncope, you start to think about whether it's ventricular hypertrophy leading to all these secondary STT changes. And also you need to start to think about sometimes in patients who have typical history, electrolyte imbalance, hypokalemia, and potassium abnormalities, magnesium abnormalities, so on and so forth. So the differential for deep T inversions is quite wide, quite different, but the clinical context is what you want to have in mind interpreting an electrocardiogram. Okay?
Yep.
3 more minutes. Let's see how much we can get through. So 36-year-old young man, I think I remember him, returned from hiking in the Alps. Dizzy spells, got admitted with 2 episodes of collapse. This was about 5, 6, 7, 9 years ago. Can we see U waves? I would say no. They are some other waves. Tell me what those waves are.
The P waves, but they're
Excellent.
not followed by a QRS complex.
Yes, so what's the electrocardiographic diagnosis?
Mobitz type 2 heart block.
Okay, make it more elegant. Mobitz type 2, 2nd degree AV block. Or type 2 2nd degree AV block, whichever way you want to say, but 2-to-1 AV block. Every alternate QRS complex is preceded by a P wave, whereas these ones are not. So what was referred to as U waves were actually P waves. What do you think maybe happened to this patient? We nearly paced him actually before we suspected something else. What causes heart blocks if you go hiking or bradycardia? Risk,
The high altitude.
high altitude. That is conditioning. If you've been going, oh yeah, who said Lyme disease? Yeah, so this was a classic, he tested positive. We just thought about it. And one day before he was going to go to the cath lab, we just thought about Lyme. And yeah, I mean, all those reasons are quite valid. Hypoxia, hypothermia, conditioning, all that stuff. And some people could be living long with these, but this is a wide QRS escape rhythm, a dangerous rhythm to leave it like that. And basically he had a tick, a bite with Borrelia burgdorferi, as you know, the tick responsible for Lyme, tested positive. I think he recovered spontaneously. Thankfully did not require a pacemaker. So this is a very good reminder to us from that particular case, big learning. This is the last one for the day, and maybe a very relevant ECG for you guys who work across all sorts of wards doing all the hard work. So just read it out and see terminal cancer, 84-year-old, anemia, end-stage renal disease, has been unwell for a couple of hours, a bit borderline blood pressure, and that's the ECG. So what's your electrocardiographic diagnosis?
So with significant ST elevation in leads 2, 3, AVL, AVF, and then V2, V1 through V4, is this potentially looking at ST elevation ACS secondary to anemia, so type 2 myocardial infarction territory?
Yeah, there was an option here, pericarditis. Wouldn't expect convex upwards elevation in pericarditis, first of all. So look at the pattern of elevation, which is convex upwards, like concave upwards, all right? So that's a classic of STEMI. And this is a rather global ST elevation, I would say, global STT change, except for these leads, but they have quite mirror type ST depressions. And what do you think is happening here? What would you treat her with?
Would you respond to therapeutic blood transfusion?
Excellent. That's the only treatment you want to give her, actually. It's secondary to hypoxia or anemia, most likely, rather than true coronary occlusion. She could have underlying multivessel disease as a result of her age and natural atherosclerosis, but all that's been made manifest in terms of multi-territory ST elevation of convex upwards type in this scenario. And you wouldn't be surprised to see one of these in your surgical placements, if not today, then sometime other day, sometime in future. I think you need to put that in clinical context again and then make a decision along with your colleagues as to yeah, I mean, that's more of a terminology and how you classify myocardial infarctions rather than truly occlusive. You're right. So that's correct. So it's not due to a thrombotic occlusion of a major coronary vessel. You're correct. So I wanted to show you just one more where you could, yeah, this was the one actually, and then we'll finish. And that will give you the right context. This is a real case. So COVID twice, recurrent chest pains, and ED attendances. He's under my care recently. I think he attended maybe a month or two ago, last follow-up. So what do you think could be, with your learnings around COVID till now? Take a look at the ECG, think what could be going on.
Widespread ST elevation.
Okay, of what type compared to the other one? So look at the pattern here. 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 And then for comparison purposes, look at the pattern here, right? This is convex upwards, 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 and this is concave upwards, right? Cross territory. What do you think would you explain to him maybe going on? Anyone? We need to finish. Pericarditis. Yeah, absolutely correct. Viral infection of heart muscle or viral infection of the outer lining of the heart, or both, until you've checked the troponin and you're not sure. If the troponin is elevated, it's myocarditis as well, or perimyocarditis. If the troponin is normal, you stay away from saying myocarditis unless you've done an echocardiogram, which reveals some wall motion abnormality, some weakness of cardiac muscle, but it might show you bright, thickened pericardium, something of that sort, or maybe a normal scan. But then the idea is within 6 weeks or 8 weeks maximum to get a cardiac MRI scan, which is the time window to pick up inflammation of myocardium or pericardium. If you miss the window, then you might not get a diagnosis, and the patient might keep coming back with recurrent pericarditis now and then. But this is perhaps something just to keep in mind. You would see loads of patients like this, COVID, non-COVID, either of them. Okay. So that's a good example of a patient with pericarditis or perimyocarditis, depending on what exactly you find after full assessment.